from to heart, free from skin and underlying muscle, no nipple discharge or distortion, no right axillary or supraclavicular palpebral lymph node, left breast axillary supraclavicular region are normal, no abdominal mass or respiratory musculoskeletal system are normal. So, how to proceed? I'll ask the radiologist or breast surgeon. How will you proceed? What sort of imaging will be appropriate for this lady?
This case has lump and no axillary swelling. So first of all, we will go through the ultrasound. Ultrasound, preferably with elastography.
Thank you. Sorry?
Just to talk about this violet classification we normally know about radiology, right? Violet 1, 2, 3, 4. Exactly the same way we do clinical assessment in America as well. I understand. P1, P2, P3, P4, P5. P1 is normal breast, nothing is there. P2 is benign finding. P3 is indeterminate, not sure if it's cancer or not. P4 is highly suspicious, and P5 is definitely cancer. So clinically also we can assess. That will help all the radiologists to find out which way people are thinking. So that's very important if we start using it now. P1, 2, 3, 4, 5. 3 is indeterminate, 4 is suspicious, and 5 is definitely cancer. Okay?
So in response to that, I will say P4.
The reason why we need to know that is if we do an ultrasound and mammogram and we find that there's no abnormality and you still think it's P4, P5, we would then suggest you do a clinical biopsy if we can't see anything, and we would proceed to do an MRI probably as well, because we are that suspicious even if the ultrasound and mammogram are normal. Does that make sense? Yeah.
Thank you.
Put in, that's also joined in now. Sorry.
Please, check for them, please. Take your seat.
Don't worry. You understand?
Okay, so this is the ultrasound of breast and axilla. 2 lesions in right breast, 24.8 into 18.3 millimeter predefined hypoechoic lump at 9 o'clock, 60 millimeter from nipple, 13.5 millimeter from skin, highly suspicious for multiple lesions, categorized as virus 5. 14.4 into 11.6 millimeter well-defined lump at 10 o'clock, hypoechoic with small cystic changes within, 50 millimeter from nipple, 6.1 millimeter from skin, and mentioned as galactoside. Multiple subcentimetry lymph nodes at right axilla, cortex thickened, normal left breast, single enlarged lymph node at left axilla, cortex thickened, bilateral axillary accessory breasts. And this is the mammogram of the patient. So it's SEO breast density C. The single irregular isodense mass at right breast, which is 13 to 20 millimeter, upper outer quadrant at deeper thigh. Single enlarged lymph node at right axilla, cortex thickened. Left breast, no mass. Left axilla, single lymph node with fatty hilum, virus 5. So I have marked suspicious lesions. So any additional imaging? Microphone please to the panelist.
In our institution, we are doing routine sentinel lymph node detection. Is there any suspicious mass in breast before surgery? We are doing sentinel lymph node detection for detection of lymph node metastasis. This is for minimal invasive surgery, and we are jointly doing this procedure with oncology from National Institute of Cancer Hospital. And so, in my opinion, further imaging, if we done, it will be sentinel lymph node detection for any sort of metastasis. In axillary lymph node.
So it's actually done during the surgery, not before the surgery.
So in our protocol, we done day before surgery,
Yeah.
and then during surgery, they search for gamma probe
Yeah, I know.
activity.
Okay. Any additional imaging I actually want to know?
Further imaging, if we want to know metastasis, then
No, not enough. Yeah, local. The radiologist, would you like to comment? Considering the breast density, because you see the mammogram and the ultrasound results are not. Yeah. Sure. There is only one now.
So here we can see two lumps.
Yes.
One lump is very well defined and another one is ill-defined.
Yes.
And if we go to the mammogram, this mammogram, the ill-defined lesion, it is representing the ill-defined lesion, irregular lesion of ultrasound. And if we go to the regular lesion of the ultrasound that has posterior enhancement, and we can think it as cystic. And this patient is 32 years old, he is breastfeeding mother.
Yes.
And the lymph nodes, if we see the mammography, the lymph nodes are having high lump. It looks just reactive. So
This one.
in my opinion, these two lesions are benign, probably with access, and the well-defined one is ornament access.
Okay.
What about the tenderness?
It was not handled.
But still, the lymph node will goes in favor of the reactive lymph node.
This one.
Yeah.
Okay.
And the irregular lump is the irregular lesion of ultrasound. In this case, I want to do ultrasound guided efforts.
Okay.
This definitely looks very suspicious. The lesion at 9 o'clock that you described looks like a U5 malignant lesion. And I would definitely need the lesion on this one here. It looks like a U5 lesion and the biopsy lesion. If you look at her mammogram, it's very dense. You said she's got ACR density C. And in that density, in the clinic setting, we would do a tomosynthesis of that breast. Because we would want to see if we can see the other lesion, we can delineate the other lesion better. And also if there are any other foci there and there. But clearly you need to biopsy both of those lesions, because the other lesion can still be an abnormal lymph node. You would also biopsy the lymph node in the axilla as well. And then if at the time I didn't add any more information, we could into an MRI.
Great. I was actually looking for MRI recommendation. So there is clear recommendation for MRI, especially in the dense breast. So this is the MRI. So now you can see there is distinct separate two lesions now here. This one and this one. And the radiologist actually thought about doing the same. So she took biopsy from 9 o'clock mass as well as 10 o'clock mass. You see, both the lesions are actually infiltrating the carcinoma, grade 2. And the ultrasound guided biopsy from right axial lymph node, this is free from tumor. And the immunohistochemistry came as triple negative breast cancer, K67 not done. So, what next? What's the plan? Yeah, we have the plan. So I'm requesting the recommendation of the panel. So,
So clinical staging is T2.
T2,
One tumor
M0.
yeah.
C T2, M0, M0.
Two tumor, but the largest one is 2.4 centimeters, something like
Yeah.
that. So this is T2, N0, TNBC.
Mm.
So the standard of care is now any tumor more than 2 centimeter or more, or N1 in TNBC, we should go for
We haven't done the
neoadjuvant.
staging yet.
In a T1, in a T2 N0 lesion, without asymptomatic patient, there's no indication of doing staging investigations unless otherwise patient is symptomatic. So in the LVC only, you have to go staging investigation like CT scan, chest and abdomen with contrast and bone scan.
Okay. Any more comments on this? Okay. Okay. So, okay. So my two questions to the panel. Number one is there any necessity of the repeat FNSO core biopsy from the right axillary bone? Because to me it seems like a bit suspicious. Number two is whether we need for FNSC from the left axilla because it was also thickened cortex. So just asking, any recommendation regarding this?
Can I answer that?
Yeah, sure.
Thank you, good question. In response to the first one, the note really looks suspicious. So there is definitely an option for doing a repeat core biopsy. And secondly, the cortical thickness is important. We need to measure it. Without you can't just say leukocytopathy, or you cannot just say cortex thickened. There is a certain number. So if it is like 2.5 or 3 or more millimeter thickened cortex, then it is a suspicious looking node. That definitely needs a tissue diagnosis. So does that answer?
Yes.
Thank you.
Okay, thank you. I got my answer. So, this is the first staging. The liver panel is normal, ultrasonogram abdomen normal, chest X-ray normal. Are you happy with that, or you want to proceed further?
So asymptomatic.
Patient asymptomatic.
Yeah. If we go for neoadjuvant chemotherapy for some aggressive myeloid tumor like TNBC and HER2-positive disease, there is a recommendation, but not a category 1 recommendation to do staging workup. The panel said you can go for this staging workup, like CT scan, chest and abdomen before NSCT is planned.
Okay.
This is a consideration, not a strong recommendation.
Okay. So actually we follow that. So CT chest abdomen pelvis normal, book scan normal, no mass. What about BRCA? Yes. Mother died of and maternal aunt died of, all in their 30s. And now she's in her 30s. Okay. Is it mandatory?
It's recommended TNG should be 16.
Okay.
You have not mentioned PD-L1.
No.
Okay.
You can recommend.
What you recommended? But if I want to use immunotherapy kind of neoadjuvant setting, I don't need PD-L1, right? Just metastatic setting is recommended, not neoadjuvant setting. If I'm not wrong.
No, you're right.
John?
Same thing applies to staging as well. If you talk about UK, if there is no suspicious or confirmed images and tissue diagnosis, then then there is no need to do any staging investigations like CT scans, bone scans, or PET CT. CT, TMBC, aggressive tumor biology does not qualify for staging investigations. But I raise my hand, I surrender. In this part of the world, any patient, whether it's TMBC or not, any breast cancer invasive, we just routinely this part of the world, they do stage investigations. And that is usually chest X-ray, ultrasound abdomen, which is in very old fashioned staging. If you want to do it properly. Like a CT chest abdomen, pelvis, bone scan, or a basic.
John, regarding PDL1. Okay, great. So now the management plan. I'll go for the oncologist first, as it is a triple negative breast cancer. Okay. So your systemic therapy recommendation?
She's only in the 30s, so I probably consider her relative fertility. So start there.
If there are just two foci and we're thinking of breast conservation post-chemotherapy, market tips in both regions, the sheep could be amenable to breast conservation.
Yeah.
Because they're at 9 o'clock and 10
So
o'clock.
we are coming to surgery a bit later. Yeah, systemic therapy recommendation. Just a general plan.
So I would like to go with dose as AC, followed by packing plus carbo, and if the patient is affordable, definitely I would like to add pembrolizumab because Dr. Peter has been shown that 65% PET rate with adding immunotherapy.
Okay, thank you. So all of you are agreeable with that? Yeah.
If not, I will definitely add carboplatin test.
Okay, great. Thanks.
Just quickly one thing, which I'm really seeing this part of the world, that they start everything done accordingly, and then chemo is given, proper response, now patient comes to you, you have no option to do anything other than mastectomy. So when you say you can disease later, before you start chemo, definitely market.
Just have a separate slide for that. I have a separate slide. So
You already started chemotherapy.
No. It's a general plan. We are discussing, not treating the patient. We are just discussing in a tumor board. Later, I have actually another separate, before starting anesthesia, I have a separate slide, so we will discuss. Don't be passionate. Okay. So, surgery is the term for you. Sheikh Ahmed, you can tell me about the surgery for breast, surgery for axilla, and even the plan after neoadjuvant chemo. So, start with breast.
I'll definitely say regarding insertion of marketplace. She definitely does not say what I agree with the comment as well, that we should keep her an opportunity to do research. If there is a good response, which I anticipate with the chemo and pembrose, and if there is a platinum-based chemo is used, which is in the guidelines in National Institute of Clinical Excellence in UK, then there definitely a good chance of clinical response and radiological response. In that case, she can have a two-wire insertion at the day of surgery, and the local anesthetics, and you could easily do two-wire wider excision, and you can go back whether the repeat code is positive or not. Even if it is negative, you can do in that case an axillary central biopsy. In that case, you can do a first section. If the node is positive, you can go for axillary clearance. Or if that previously mentioned repeat code biopsy was positive, you can go for upper axillary clearance. But some developed part of the world, they might want to put a clip at the positive node, and they can do a target axillary resection. That can sometimes be discussed later on. So that will be the surgery. And in case if there is no response, then obviously there is a patient choice as well. You need to discuss both about type of surgery, whether you need to go for an my practice, I always tell patients the benefits. If a patient has a breast cancer surgery, she would have a better survival benefit, less chance of recurrence, based on many population-based studies in the Europe and USA. So as long as we mention this patient, then it's good. Because often we say it's very safe if you do a mastectomy, and patient is sold immediately. So I would request everybody who is present here, please refrain from making these sort of comments because it will confuse patient. And there must be an informed choice. Like you need to tell patient about the risks and benefit of a breast cancer surgery and mastectomy in terms of recurrence, in terms of better survival, and in terms of cosmetic outcome, and obviously psychological parties often get ignored. Thank you.
Okay. Anything else, Dr. Samia?
Describe everything about the surgery in the breast and everything. But before that, I have one question about the BRC status.
So it was not done. No,
So
it was not
my
done.
question is, what will be done if she has BRCA 1 or 2 positive?
Uh,
Will we go for breast conservation?
Does it change? No, I think no. But still, the panel can decide. If it is a BRCA 1 positive, still we can go for breast conservation.
For the BRCA 1 and 2 positive patients, we are offering prophylactic bilateral mastectomy for the patient
Dr.
who is
Zakirullah,
already a
would you like to
patient.
comment?
What
If the
we-
patient is BRCA 1 and 2 positive, should we change our surgical plan or not?
We can't change our plan. We can give the risk benefit of this patient. Basically, we always discuss with the patient. If somebody has a more than 29% risk of having breast cancer, then we consider it's a high risk case. So if they're BRCA1 or BRCA2 gene positive, as we know that BRCA1 is 75 to 85% chance, lifetime chance of having breast cancer after breast. But BRCA2 is about 65 to 75%. So we have to tell all these kind of things. It's patient's choice at the end of the day. We can't force anyone.
In that case, you need to think about ovary as well. You know, so patient needs to know the risk of not only the breast, but also the ovaries.
Yeah.
Thank you.
Sir? Okay. Thank you.
Now there is no data to recommend that this is inferior to mastectomy in BRCA mutated patient. But having said that, it is also written in the guidelines that you have to counsel the patient regarding bilateral prophylactic mastectomy, as these patients are more prone to develop in breast recurrence and primary to the opposite breast. So you have to counsel the both and the patient.
Okay. So, before starting NSCT, we have a few points like marker clip at breast, marker clip at axilla plus minus, fertility counseling, and genetic counseling. So, these are the recommendations of NCCN. And margins, just for the young surgeons, recommendations for margins. Dr. Shekhpuri, anything?
In UK consensus meeting, the agreement was 1 millimeter clear margin is deemed safe for both invasive cancer as well as DCIS.
Thank you. So, adjuvant, if there is complete pathological response,
No adjuvant needed.
okay,
She's having immunotherapy.
okay. Okay, if residual disease after adjuvant,
So, consider adjuvant vaccines being interested in the UK. Seems to be a trend to treat new
okay. But if BRCA positive, do you change your regimen?
So there's the extent of carrying and ideally if you continue the population of
Okay. So with this, our first phase is over. Can we continue to a second phase?